Welcome to another episode of K&K Real Talk. Today I have Sony Singh with me today. Sony, why don't you introduce yourself?
Hi, and thanks for having me. My name is Sony Singh, and I'm a gynecologist at the Ottawa Hospital, which is also affiliated with the University of Ottawa. And I mainly focus on complex gynecologic conditions, such as endometriosis and uterine fibroids. And I'm glad to be here.
Well, thank you so much for finally being on the podcast. I know we've been trying to connect for a little bit, and you're crazy busy. You have a more than full plate, I'm sure. So we'll get right into the questions that I've got for you today. So what is the correct way to explain what endometriosis is in the medical definition? And then what would it look like in the body?
So endometriosis has several definitions, and I think the first and basic definition is what you see and what you can study if you've cut it out of the body. And so endometriosis is tissue that's similar, but not exactly like the lining of the uterus. So a common basic way that we've learned about it is that it's the glands and the tissue around the glands that are usually in the uterus, but now they're growing elsewhere. And the reason we have to put that caveat in place about the fact that it isn't exactly like the lining of the uterus is because it does behave differently. And when we diagnose endometriosis and find it outside the uterine cavity on the ovaries, fallopian tubes, actually many different places within the body, and we study it, we realize that it has its own characteristics which make it a disease process. The second definition that I think it's important to consider is the clinical definition. So many have come to call endometriosis another form of perhaps pelvic pain. And I think that's important to differentiate. Endometriosis isn't another name for pelvic pain or painful periods, but rather a condition that we find at the time of surgery if we cut it out. And the reason I think that second clinical definition is important is because there are many different causes for pain. So pelvic pain may occur due to endometriosis, but endometriosis doesn't always result in pelvic pain. The same thing with infertility. Infertility is a symptom of endometriosis, but the two may not be related as well. So I think there's the histologic or pathologic diagnosis, which we've gone over, but the second diagnosis the second terminology is very important to not equate endometriosis as a symptom in and of itself, but rather one possible cause for the symptoms and signs that we may see in some patients.
That's great. So what does it look like in the body? Like I have read, we know about adhesions and lesions usually, but I've read that it can be different colors, even like white and red and black and sometimes blue.
So Kristen, I think one of the most important things that we've learned over the last 20, 30 years is that there are different forms of endometriosis. And I think that's also important to convey to your readership or to your listenership, which is that classically we focused a lot on the fact that endometriosis had specific appearances, which really were mainly focused on what we called superficial endometriosis. And so that's one form of endometriosis. The other two forms are ovarian endometrioma, so cyst-like structures, usually in the ovaries, that are filled with material that looks like liquid chocolate, and that can fill the ovary, and that's called an ovarian endometrioma. And the third form is deep endometriosis, and that type of endometriosis can invade or start to infiltrate into the organs around the pelvis, which include things like the bladder, bowel, the ureter, which is the part that connects the kidney to the bladder. And if you took a look at that, it looks very different than all the classic descriptions that were written. So the classic descriptions of the red lesions or the brown lesions or the white lesions were very much focused on the superficial endometriosis, which if I put a scope into a patient who has endometriosis, on the surface of the lining of the abdomen or pelvis and the structures, you would see blebs of redness or brown spots or black spots. And depending on the time and the duration that they've been there, they may undergo different changes. But that really talks about one form. And then the other two forms I've mentioned, we have to convey and get out there to your listenership that endometriosis, from what we were taught versus what we've talked about for all these years, is actually not one disease, but many different diseases. So it looks very different. And the reason I think it's important for the public to know about this is that then we get out the word to our clinicians, our patients, that in fact we're dealing with more than one type of situation. And endometriosis is not just a simple finding where it looks like a couple of blebs or spots, but rather can be quite complicated. I hope that helps. I know I took a little bit of time to explain that, but I think it's so important for people to understand 3 different forms of disease. The ones that you were talking about that are classically written about a lot are what we call superficial disease. The other one is that chocolate cyst-like structure. And the third one is that deep disease, which doesn't look like any of the other two and actually invades and causes a lot of scarring.
I think that was great. I think that's a great way to describe it. And I really do think that it's important that we understand that there's more than just the superficial endometriosis that you see usually on the tissue that's holding in like the female reproductive organs, and that there is more to it than just on top of the organs. It's great. So what do you think would be the easiest way to explain endo to family and friends if I'm just recently diagnosed?
That's a hard one because, as you know, and your listeners, yourself and others, find that that's a very hard thing to communicate to families, because on the surface, being your outside perspective, many of our patients look actually very healthy. And the struggle they're having is very internal. So you can't see the endometriosis on the outside. And the struggle, the effect on one's well-being, both psychological and just coping, is often internal. So I'm glad you brought that up. I often want the family members to be there so that I can help validate that our patients are not crazy, that they have experiences of pain and struggling, and that there is help out there. So I think what I try to convey to the family members when they have a diagnosis of pain, and I think I'm going to go back a step and not just focus on endometriosis, but pain in general, is that patients should be believed if they're struggling, that they need to have support and get help, and that there are many women in this situation. So what I often tell my patients is that you're not alone. Across the country, many are suffering. And I think that in and of itself is important to validate that pain, whatever the cause, needs to be managed. And I think that family members and loved ones need to know that this is a journey and that our goal together is to make the patient feel better. When it comes to talking about endometriosis, I go back through the similar stuff we've talked about, which is that this is tissue that is growing on the lining of the abdomen on the inside, or the pelvic structures or organs or elsewhere, and that it may in turn cause issues with fertility, getting pregnant, may cause issues with pregnancy. The third thing that, again, your listenership should know, many times there may be no symptoms, and it might be an incidental finding. But it's important to communicate that basic understanding so that they can understand what's involved. When I get into the more complex disease processes where organs are involved, that's a smaller percentage of all women who have endometriosis, then I start to describe things like their organs were stuck together, or that the ovaries were damaged from the disease if they were endometriomas, etc. So I think in summary, first and foremost, regardless of what is underlying it, validate the pain, get the family unit involved or friends and loved ones involved to say, we're going to help. And finally, if the cause or source is endometriosis, work in explaining how it's involved and what the long-term plans are.
And I definitely agree that support of family and friends is definitely, it's important. And family and friends can only understand so much. So that's why I created Endometriosis in Me, is to be able to connect each other and have endo sisters talking about endo sisters so that they can really understand what each other is going through. So I would definitely say support is number one. And so thinking about surgery, I know that when you did my surgery, I had a hysterectomy and it was laparoscopic. And I'm still hearing about a lot of doctors doing open abdominal surgery rather than going the laparoscopic route. And like, why would you think that is?
So I can't comment on what others do or what they do. I think it's also important, I should not comment on individual cases as well, right? So we'll avoid, I won't be commenting on any specifics, but I think you bring up a very good point. I think my goal and the goal of my colleagues who do minimally invasive surgery is to increase access for women across Canada and across the world to better care. That means better medical care, means better diagnosis, and when and if surgery is needed, better surgical care in the least invasive way possible. So what we have shown is that we have made a change. So in the last decade, for example, we've published a paper in my own institution where we went from about 40% of all hysterectomies, as one example, not to do with endometriosis alone, were done in a minimally invasive way. Today, after implementing lots of change, 75 to 85% of those cases are now done through the less invasive way. So I think our job is to get the education out there, bring everybody up to the standards we would expect, and then offer women the best choice possible. And with endometriosis specifically, there are different disease types, as we've talked about, and we have to figure out how to make sure, if surgery is needed, how to make sure the patients get the best care possible. And that will involve patient education, surgeon education, family doctor education as well.
I couldn't agree more. And like, it's different. It's funny when talking with other endo sisters of the different types of surgeries we have and so on. I know that I didn't have my ovaries removed, but I'm so thankful that it was laparoscopic, because one of my admins on our closed Facebook group, she had the open abdominal surgery and her recovery was just horrible and long, where I felt my recovery was so quick. So I am all on board for doing it laparoscopic. Like, the patient should be the number one concern, and maybe it comes down to comfort level for the doctor, but every doctor is different, just like every case of endometriosis is different.
And I
So
think it's important also to note that in some cases, open surgery is still required. And to be honest, in our practice, we have probably, the most severe types of disease referred to us just because of what we are. And so we have to decide on what is the best and safest way. But I think the point that you've brought up is essential, is that if all things are equal, the patient should be accessing what's best for them rather than what is best for the local institution or the local surgeon experience.
I totally agree. And that's why we have to advocate for ourselves and do our own research to find what's best for us, and not just do the first thing, really do the research. So in your experience, what would you say that is the most effective treatment?
So that is a very hard question. The most effective treatment is the one that is best for the person sitting in front of me that day. Every treatment has to be personalized. And it's essential for that message to get out, because there is no simple pill, there is no surgery that is going to cure the signs and symptoms related to endometriosis. And I think that's a very important message to get out, because again, when we look back at what we're treating, we're not treating the disease alone, but rather we're treating a cluster of symptoms. So if a patient comes in and fertility is their goal, wanting to get pregnant, and they have no pain, then we should advocate for them to try whatever it takes for them to get pregnant. And there are many options, whether it be medical, maybe surgery, and then of course, fertility treatments. The important thing about that scenario is if you automatically operate on every patient who wants to get pregnant despite symptoms, even if they have cysts in the ovaries, it's important, and we haven't gotten this word out, Kristen, it's a big issue, is you can cause damage to the ovaries, and then the ovaries don't work. And the chances of getting pregnant go down significantly. And so the harms of surgical intervention in that case have to be explained. Whereas you have somebody who has lots of pain. And again, you have to decide on what their goal is and how to treat them and where they are in their life in terms of whether they want to have kids soon, later, or they're not actually interested in that at all. So in summary, I think the right answer is personalized approach. We should be very careful not to say that there's one thing that fits everybody. And my belief and my philosophy, along with many others, based on guidelines that we've written and others have, is that you have to look at the entire lifespan of a patient with endometriosis and try to do the best thing. And if that means medical management to treat symptoms, if there is no complex disease, then that's reasonable. If medical management doesn't work, or if a patient wants to get pregnant and they have pain and we know that medical management will prevent that, then surgery is right. But we're really advocating for ideally one good surgery in the endometriosis lifespan, if possible, and that medical therapy should be used before and after, because we know that it can prevent recurrence and it can help overall. And I think that's where we're trying to go with the message. And not enough people talk about the fact that it has to be personalized and we can't treat everybody different. The only last point I'll bring up that's very important that we don't talk about, healthcare system and access to health insurance changes things. And I've seen that across the world. So in a public healthcare system like that, we have an opportunity to have surgical services covered. If you have health insurance, you may have medications covered. In countries where people don't have access because they have to pay for these things and it's too expensive, then they may not get access to either medical or surgical options. So I'll just stop there and say that it's personalized approach. And I think I hope that that comes across, because it should never be this one answer for everybody.
I totally agree. And I always say that this disease is very individual. It's a whole body disease. And for treating symptoms and the disease, it's really trial and error, because what works for me is not going to work for the next person necessarily the same way.
Can I make a point about the trial and error?
Of course.
So I think what I'm trying to teach, and others are trying to teach, is that we can decrease the trial and error if we were able to communicate to healthcare practitioners and the public and patients the importance of the initial assessment earlier in life, the importance of taking a history, examining a patient, doing the right imaging. And when we get all that information and we start to think about all the different issues that can happen, then hopefully we'll be more targeted and people will do better. Because that worries me, that if we don't do it right the first time, and I always think about my own daughter, if she has to go through this, is I don't want people to suffer and go through many cycles of that. So ideally, when somebody's young and they present with pain, you do a good history, a physical exam, do an excellent ultrasound, which again in Canada is not available widely in terms of the quality. And then you can go along that path of saying, okay, based on all this information, we think this is the right thing now versus option 2. And then we can look forward to a lot more success. And I think that would be my dream, is that we would teach better so that it would be less about trial and error rather than personalized medicine, where based on your symptoms, based on all the findings, for the rest of your life, for the next 50 years, we know that this plan will make you have the best outcomes for pain and getting pregnant, etc. And for person 2, this would be it. And that's what we have to do. We're not there yet.
I agree. There's so much more research and education that needs to be done. So moving on, I know that right now the medical gold standard is excision surgery. So could you explain what exactly happens during an excision surgery?
So, Kristen, it's interesting that that has been commented on as being the gold standard, because I think, going back to our earlier discussion, the gold standard really depends on the patient. In terms of the surgical approach, and yes, I am, I guess, by definition, an excision surgeon. And for your listenership, what it means is that when we see the disease, we cut out the disease that we can see rather than burning the lesions. But the important point is, again, going back to what's right for the patient. So excision surgery, just to explain it, is that you see a lesion on the lining of the abdomen, which again is on the inside, taking that tissue that you see is diseased and cutting around it to remove it. If you see that spot on the ovaries, cutting into it, removing it. If you see that spot on the bowel, doing the same. However, the reason that we have to be careful and we have to go back to a personalized medicine approach is, as I mentioned earlier, we have to balance the risks and the benefits for each patient. So it's considered the gold standard because it gives you pathology, so I can confirm under the microscope that it is endometriosis. However, unfortunately, we do not have good medical trials showing that cutting out as much of the disease as possible is going to cure patients better than, for example, medical therapies, or cutting out part of the disease, or even burning the disease. And the reason I think that's important for the listenership to know about, and again, my bias is my whole practice is based on cutting out disease, but it's important to be honest, because all the reports that have been published are, not all, but many, are actually what we call case series. They come from single surgeon experience, or single institution, which says, this is what we do, and our patients did amazingly well, and so we believe this is the way to go. What we need to do in Canada is a proper trial comparing medical, surgical, and other in-between options, and then decide which one is better. We've done it for cancers, for ovarian cancer and cervical cancer and other cancers, but endometriosis is missing that. And I apologize for taking this turn in terms of trying to describe to your answer, but I think it's very important that we just be honest. Again, I do this type of surgery on every week, several times, but I think we have to be careful when we say, is it the gold standard? It's gold standard for diagnosis. It's certainly what I believe in, but we have to be careful that it may not be the right thing for everybody. And with any surgery, there is a risk, just like with medical therapies as well. And hurting the ovaries in a young woman who wants to get pregnant is one of my biggest concerns. So is it right to cut out all the tissue in the ovaries if somebody's young and wants to get pregnant? Because their ovarian reserve, or their ability to conceive, might actually go down. And we have that evidence. So I think that's, in summary, I've given you sort of the background on why I'm cautious. I've explained what excision is. And moving forward, I'll continue to excise, but I hope my colleagues will, in the meantime, balance what's best for the patient's future and their goals, and try to balance how much to excise. And I think that's where the art lies. You don't want to cause so much damage that it hurts the patient, and yet you want to do enough to help them.
I totally agree. Patients first. Everything is individual. So I'm going to move on to a couple of questions about you. What are you currently working on?
Well, we got lots that we're working on. We love our job, and we love the patients that we see. So we can look at it in three ways. One is education, doing what you're doing. I think it's amazing that you're getting the word out there. And, I think the more we can talk, the more we can clear the air, because there's a lot of confusion for patients and they just want help. So education and outreach is a big part of it. I certainly want to be more involved, and I think trying to help individuals like you get the word out even to the provincial or federal level of government, to say that we need more attention in this space and that we need to work on making sure there's better access. So the current thoughts that I have, and I'm hopefully going to put something on LinkedIn soon to get some feedback, is that we need a strategy like they do in Australia, or they're working on in Australia, where when a young woman has pain or fertility issues, that she quickly be identified and there would be a standard of care. And that would be with family doctors or general gynecologists. I think 80%, if we could teach it well, 80% of issues could probably be managed in that realm. But when people are struggling after 3 to 6 months of not responding to primary options, then we need local gynecologists who are experts in each region. And as you know, we have a fellowship, and I've trained over the last 10 years many of the surgeons, just like my other colleagues have trained people across the country who now are set up from East Coast to West Coast and can give that level of expertise. And finally, probably only about 5% of all women with endometriosis who have very complicated very difficult situations need to be able to access centers of expertise where there's bowel surgery, diaphragm surgery, very complicated things. But once we create that and the word is out there, I think we'll get care to women earlier. So that's sort of the one passion project I have now. We're doing some work on research side, both looking at quality of surgery as well as medical options, new medications or future medical options, which hopefully have less side effects for women. And then finally, the clinical side of what we do is very busy, and we just want to continue to help women locally and advocate in the country to really give our patients a holistic approach. So when we see them, offer as much as we can that's right for them, and that means more than just managing endometriosis, but managing pain as a whole.
And I love your clinic. Everyone is super nice. I've been lucky enough to meet two of the doctors that you have trained. One when I was seeing you in Ottawa, and one that moved to Kingston. And they are also amazing. So I really admire your work. Can you talk a little bit about what you think the future of endometriosis treatment and diagnosis might look like?
I'm glad that we've had this discussion today, and I hope that the future has been scattered through our discussion, which is personalized medicine, more information and access to information for women on chronic pain, understanding pain. I think physicians should also understand pain and be able to communicate it better, because while we're working on improving endometriosis care with medication and surgical excellence, we're missing the bigger picture, which is that not all women with chronic pain have endometriosis, or not all pain is due to endometriosis. So this is one area we can anchor excellence in, but when we develop our future, it has to be holistic. When you come into a place, we need to have physiotherapy, we need to have social work, counseling, teaching about bladder health and bowel health all together. And I think that would be the future. And some places in Canada are doing it already, and we're certainly working towards that.
Yes, exactly. It's not just a pelvic disease. Well, thank you so much for being on my podcast today. And I really appreciate you taking the time out to educate our followers a little more. And I hope that everyone will spread the disease information or the awareness around everywhere, and just let anyone they can know. And even they could give them some episodes of the podcast to watch. If anyone has any questions or would like to see Dr. Singh on the podcast again, let us know in the comments. So thank you so much for being here.
It's my pleasure, and keep up the great work.
Thank you so much.